Hey everybody. So for my clinical pattern, I had total hip arthroplasty with a focus on the posterior approach. So typical patient demographics are ages 50 and above. It varies a little bit within this population. Typically, the most common ages are like 60 to 80. It can occur in younger populations, but it's very rare. It occurs slightly more in women than men. Two common outcome tools used are the lower extremity function scale and the Harris hip score. Typical mechanism of injury is a femoral neck displacement due to trauma, such as like a fall or a car accident. Some aggravating factors pre-surgical are weight bearing and resisted movement. And then some easing factors are medication, rest, and non-weight bearing. Typical 24-hour pattern is consistent pain throughout the day that's exacerbated with activity during early stages of post-op. There's no need for a systems review or review of systems since we already know the diagnosis. Precautions and contraindications, like we've learned before, for posterior approach, it's flexion past 90 degrees, extreme internal rotation, and adduction across midline. And then for an anterior approach, it's extension, extreme external rotation, and adduction past midline. For physical exam, active movement testing and passive movement testing are the same. So we wouldn't perform hip adduction past midline. We would perform, so with hip abduction, it'd be limited and most likely due to pain. Flexion, again, limited due to pain, and we're not going to perform this past 90 degrees so we don't break precautions. And then hip extension, also limited due to pain. There may be some muscle guarding as well going on with that post-surgical. We wouldn't perform resisted testing, any accessory motion testing, or neurodynamics. Um, Neurodynamics would all come back negative, most likely as if we perform them. So we don't perform those. Palpation, you probably have tenderness over the surgical site, like at the glenohumeral joint, and the surrounding musculature, and most likely there'll be inflammation in that extremity. Special tests we won't perform either, since we already know the diagnosis. For differential diagnosis, that's not involved either since we already know. And then for imaging, typically none is done post-surgical because surgery has already been performed, and we want to see and we know how the surgical site is. Pre-surgical, sometimes MRIs are used or X-rays, radiographs beforehand. So some common signs and symptoms to indicate referral back to the doctor. Signs of DVT, increased swelling, erythema, calf pain. Signs of any pulmonary embolism. If the patient is having uncontrolled pain. Signs of any possible dislocation. So some of these could be like an obvious leg length discrepancy from one side or the other, or an appearance of internal or external rotation of that lower extremity that's involved. And then we want to look at integumentary concerns of the incision site. So skin discoloration, edema, excessive bleeding, or drainage, all things that we want to be looking out for. And then we want to look out for signs of periprosthetic fracture, which would be something along the lines of like loss of peripheral nerve sensation. So that is something that we want to monitor as we progress through our interventions. And then lastly, surgical indications, none because we've already had the surgery. So yeah, so that's total hip arthroplasty. Thanks.